Thank you very much for your kind introduction. Congratulations to Boston Scientific for the whole organization of this event, and thank you very much for the invitation. I'm going to speak today about a problem that we all have, this loss of efficacy over time or the loss of analgesic benefit over time. Why do we see something like this? Because of the synaptic plasticity of the pain transmission pathways, because of the tissue remodeling, because of fibrosis, around the leads, because of the fact that the patient pain perception evolves or changes over time. And we know, according to NAC, published in Neuromodulation 2014, that up to 30% of patients could face such problems. So, when multiple programming sessions have failed, these spinal cord stimulation systems may be explanted. Virginie already mentioned these numbers, 3 to 6% annual explant rates. And if you find some time, this publication from Van Buiten in Neuromodulation 2017 is really interesting. You can see that 5 years after implant, almost 20% is the probability of explant. So the question is, how can we manage the loss of efficacy? How can we avoid the explants? Always keeping in mind that it would be for the patient really good to avoid the explantation of already implanted leads. Nowadays, we have a new technology. We have new stimulation modalities. We have new waveforms, new stimulation paradigms. And with these paradigms, we can target different neural structures. And this may improve our ability to adapt the therapy to the nature of the pain and to the changes in patient response over time. We can now, at the same time, target the dorsal columns, but at the same time, we can target the dorsal horns. So I'm here today to present our clinical experience, the clinical experience of our department. This is the publication of our team with Pablo Andrade, Petra Hayden, my director, Verle Fisavadevale, and myself in Neuromodulation 2020, impact factor of 4. It is actually a 6-year retrospective record analysis to identify spinal cord stimulation patients experiencing refractory chronic pain with loss of efficacy with their conventional therapy. The loss of efficacy was defined as complete loss of effect or as similar pain scores in on and off stimulation. The patients had 3 options. First, to continue with previous parameters. The second, to complete a spinal cord stimulation system explant. And the third one, to undergo an invasive trial with new spinal cord stimulation options. Once again, what was important for us and for the patient was to avoid explantation of already implanted leads. In total, we had 37 patients, 18 females, 19 males, with a mean age of 60 years. They had used conventional spinal cord stimulation therapy for almost 3 years with devices from different companies. The main indication was for 70% of the patients failed back surgery syndrome. But we had also patients with degenerative back and leg pain who did not want to undergo a bigger operation, a general neurosurgical operation or orthopedic operation, patients with complex regional pain syndrome, with diabetic foot syndrome, with pelvic pain syndrome, and some other etiologies. So what we did, we disconnected the leads from the IPG, we connected the leads to extension cables and we externalized these cables. We started the trial the same day of the procedure, and the trial lasted maximum 20 days, in the majority of the cases 7 to 10 days. Previously, we had monotherapy. Monotherapy is a tonic stimulation or a burst stimulation or a stimulation with 200 Hz or 1.2 kilohertz. Now, with this new technology, we have a combination of waveforms. We can combine tonic with bursts or tonic with 1.2 kilohertz. For example, successful trial responders was defined as a reduction of the pain of at least 50%. We followed up these patients after 1, 3, 6, and 12 months. The responders are with gray color here, and with white color, you can see the non-responders. 8 were non-responders, 29 out of these 37 patients were responders, so a responder rate of 80%. For the whole cohort, also for all 37 patients, the baseline score was 8.1, and post-trial, at the end of the trial, the score was 3.8. After 1 year, the score decreased by 4.5 points, or if you wish, 43% at 12 months. After 1 month, the score was 2.7. After 6 months, 3.7, and this stayed stable after 12 months, 3.5. Once again, these are the results for 29 responders. Before the rescue therapy, 90% of the patients were receiving a single waveform. After the rescue therapy, 90% of the patients reported better clinical outcomes with combination of multiple waveforms. Most of them wanted to have a combination of tonic and burst or microburst, or a combination of tonic and 1.2 kilohertz. There were also patients with burst and 1.2 kilohertz, and for me, it's more interesting to see that there were patients that liked only contour, so a subperception stimulation algorithm with 200 Hz. So this study showed that the rescue therapy with novel spinal cord stimulation paradigms and combination of multiple waveforms was associated with a significant pain relief in patients with failed conventional spinal cord stimulation systems. The waveform combination is safe and efficient and should be considered before explantation of the spinal cord stimulation system. If I make a comment, some days ago, we watched an INS webinar on spinal cord stimulation therapy, and I was surprised to hear from very good, very esteemed, and very experienced colleagues that they would not try a rescue therapy by the majority of patients who come to their offices with a habituation. And it was even more interesting to hear that there are no publications that would support such a concept. Interesting enough, there is a publication, our publication, and interestingly enough, this publication was accepted and published in the official journal of the INS in Neuromodulation, Technology, and the Neural Interface. Just a small comment. And an overview of the waveforms, let's concentrate at 12 months postoperatively. With white column, you can see the combination of tonic and microburst or tonic and 1.2 kilohertz, with gray burst and 1.2 kilohertz, and with black the contour. For me, once again, it's really interesting that there were patients only with contour, so without any combination therapy, that were really satisfied. But at 12 months, you can see that the majority of them wanted to have a combination of burst and 1.2 kilohertz. So, is this technology the solution to all our problems? Unfortunately, no. We have now many more weapons to treat many more patients with chronic pain, but not all of them. And this is the challenge for us as physicians, and this is the challenge for all companies that are involved in this field to come up with new waveforms or with new technologies that would help us treat all patients with chronic pain. Today, I found something really interesting on Instagram. Somebody wrote, pain patients are like potatoes. Each one is completely unique and different. No two are the same. And this, I think, applies very well to our chronic pain patients. The second point is that the chronic pain patients do not belong, they are not the property of a specific physician, and they don't belong and they are not the property of a specific company. So I believe that we should try all options in the context of spinal cord stimulation therapy, that we should try all waveforms and combination of waveforms for all patients before we say that a chronic pain patient does not respond to this therapy option. Of course, there are some MRI concerns. If we implant a lead from company A and then an IPG from the company B, we have no MRI compatibility. And this could be a problem in specific patient groups, for example, patients with multiple sclerosis. This is why now we have a new solution to these problems. We have a new technology, we have new IPGs that can apply all these forms or combination of them, and the IPGs are at the same time MRI compatible. This photo shows the first implantation worldwide of the WaveWriter 16. So now I believe we have a new era in neuromodulation, but of course we should wait some years from now to see what happens after 5 or even more years if we have found the solution to this habituation problem, or if we should keep working on it. Thank you very much for your attention. If you have any questions, I will be glad to answer them.